Welcome to The Explainer. Today, we're going to build a really solid mental model for one of the most common valve problems you are definitely going to see on the wards, mitral regurgitation. By the time we're done here, you'll have a clear, step-by-step way of thinking about it, from diagnosis to management.
All right, so here's our game plan. We're going to follow the clinical journey, just like you would with a real patient. We'll kick things off with the basic problem, then talk about how to find it and figure out what's causing it. After that, we'll get into the treatment playbook and wrap up with the absolute must-know points.
So first things first, the leaky valve problem. Before we can even think about fixing it, we have to really get what's going wrong at a fundamental level. What is the core issue when that mitral valve starts leaking?
At its heart, pun intended, mitral regurgitation is a volume overload problem. It's really that simple. Instead of all the blood shooting forward into the aorta like it's supposed to, a big chunk of it leaks backward into the left atrium, every single beat. This creates this super inefficient circuit that the heart just has to struggle with over and over again.
Now, what's fascinating is how this problem can show up. It can be a total catastrophe out of the blue, or it can be this slow, sneaky thing that develops over years. Acute MR, let's say from a ruptured cord, is an absolute disaster. The left atrium has zero time to prepare for the sudden gush of blood, and boom, flash pulmonary edema, cardiogenic shock. But with chronic MR, the heart is clever, it adapts. The left atrium and ventricles slowly stretch out and dilate over years, so patients can actually feel fine for a very long time.
All right, let's move on. Now that we know what it is, how do we actually find it? How do we confirm our suspicion? And, maybe more importantly, figure out just how bad the leak really is? This is where your clinical skills meet the technology.
Okay, before you even think about ordering an echo, remember that your hands and your stethoscope are your first and, honestly, your most crucial diagnostic tools. The physical exam can tell you a ton about whether MR is present and maybe even how severe it is. So what are you looking and listening for?
So you're going to hear that classic, blowing, hollow systolic murmur, right at the apex, usually radiating out to the axilla. If the cause is mitral valve prolapse, you might hear a little mid-systolic click just before the murmur. And don't forget to put your hand on the chest. As that left ventricle gets bigger from all the volume overload, you'll feel the apical impulse shift way out to the side. And an S3 gallop, well, that's a dead giveaway for that volume overload and often means the LV is starting to struggle.
Now, as important as the exam is, you gotta get the echo. It's what gives us the hard numbers we need to make the big decisions. It is the gold standard, period. It confirms the diagnosis, it tells us why it's happening, and crucially, it lets us grade just how bad that leak is.
So how do we actually define severe? Well, the guidelines give us a few key numbers to hang our hats on. The first one you see here is the EROA, or Effective Regurgitant Orifice Area. You can just think of this as the size of the hole in the valve. If that hole is 0.4 square centimeters or bigger, we're in severe territory.
Next up is the regurgitant volume. This is pretty straightforward. How much blood is actually leaking backward with every single beat? The magic number here is 60 milliliters. If it's 60 or more, that's another check in the severe column.
And finally, we look at something called the vena contracta. This is the narrowest, most high-velocity part of that leaky jet. If it's 0.7 centimeters wide or more, you guessed it, that also points to severe MR. So you've got these three key metrics, the EROA, the regurgitant volume, and the vena contracta, that are your foundation for grading.
Okay, we've now arrived at what is probably the most important fork in the road in this entire clinical pathway. Once you've confirmed that a patient has severe MR, the very next question you have to ask is, why? Because the why is going to completely change what you do next.
And I really can't overstate this. This isn't just some academic classification. It fundamentally changes your entire approach. Are you going to target the valve itself? Or are you going to target the ventricle that's causing the problem? Getting this right is absolutely everything.
This table lays it out pretty clearly. In primary MR, the valve itself is the problem. It's diseased. Think of a floppy, degenerative valve from mitral valve prolapse. But in secondary MR, the valve is actually an innocent bystander. The real culprit is a sick, dilated ventricle that's stretched out and it's pulling the valve leaflets apart so they can't close properly.
All right, so we've confirmed the diagnosis, and we figured out if it's primary or secondary. Now we can open up our management playbook. As you're about to see, the right move is completely different, depending on whether we're talking about an acute problem, a chronic one, and of course that primary versus secondary distinction.
So let's start with the most dramatic situation you can imagine. Your patient comes in gasping for air, hypotensive, in full-blown cardiogenic shock. from, say, an acute chordal rupture. This is a true cardiac emergency, and you need to act fast to get them stable enough for the definitive fix.
The strategy here is really twofold. First, you have to stabilize them, right? You medically bridge them. The key is to reduce afterload, make it easier for the heart to pump forward. So you use powerful vasodilators like nitroprusside. Sometimes an intra-aortic balloon pump can help too. And once they're as stable as you get them to the operating room fast.
Now let's switch gears to the much more common scenario, the patient with chronic primary MR. Here, the name of the game is timing. It's everything. Your goal is to intervene before the left ventricle gets permanently damaged from years of that volume overload. So what are the tripwires? What tells you it's time to call the surgeon?
These triggers for surgery are crystal clear, and you have to know them cold. First, the obvious one. If the patient has any symptoms you can blame on the MR, that's it. Time for surgery. For patients who feel fine, though, we operate when we see that LV starting to give out. Now here's a classic pearl and a common pitfall, an ejection fraction of 60%. You might see that and think, hey, that's normal, but in severe MR, it is not. The ventricle has an easy out, pumping blood into the low-pressure left atrium, so the EF is artificially high. If it drops to 60%, the ventricle's already failing. The other trigger is the LV just getting too big, an end systolic dimension of 40 millimeters or more.
And now for secondary MR. The approach is a complete 180. Remember, the valve isn't the problem here, the ventricle is. So just going in and fixing the valve isn't your first move. And honestly, a lot of the time, it might not even be the right move at all.
Your absolute focus has to be on optimizing what we call guideline-directed medical therapy, or GDMT, for heart failure. This means pushing medications like ACE inhibitors, beta blockers, and aldosterone antagonists all the way up to their max tolerated doses. The whole idea is to help the ventricle get stronger and maybe even shrink a bit, what we call reverse remodeling. And if you can do that, a lot of times the secondary MR will get a whole lot better all on its own.
Wow. Okay, we've covered a ton of ground, right? We've gone from just hearing a murmur all the way to making complex decisions about the operating room. So let's boil this all down to the key things you need to take with you and apply at the bedside tomorrow.
If you remember nothing else, remember these 4 points. 1. Acute MR is a surgical emergency. Don't wait. 2. That primary versus secondary distinction is everything. It drives your entire plan. 3. For primary MR, know those surgical triggers, symptoms, an EF of 60% or less, or an LV end systolic dimension of 40 millimeters or more. And 4. For secondary MR, treat the ventricle first. Always optimize their medical therapy. And that brings us to our final thought. We've talked a lot about surgery, but the whole field is changing. We now have tools like transcatheter edge-to-edge repair that are a real game changer, especially for patients who are too sick for open-heart surgery. This just means that all the strategies we talked about today, they're going to keep evolving. It's what makes this such a dynamic and really fascinating field to be a part of.